My name is Sanjeev Bhalla, and I'm a professor of radiology at Washington University, and I run the cardiothoracic imaging section here at the Mallinckrodt Institute of Radiology in St. Louis, Missouri. This is a set of criteria that are used to follow patients who receive treatment in order to try to have something more objective to understand if the treatment is working or not. So the RECIST criteria it's an acronym for Response Evaluation Criteria in Solid Tumors. And there is a RECIST 1.0 and then more recently a RECIST 1.1 that's used to give us some approach to taking all of the various findings on a CT image and try to give it some numerical value that can be then used to follow patients. And so what will happen is that in the RECIST criteria, we have a certain size criteria that is needed. It's on 5 millimeter thick images. So it's important that your CT that you're using as your basis of RECIST has a 5 millimeter thick slice or fewer millimeters in each slice. That is used to then allow us to measure lesions. And so we measure what are called target lesions in an organ. And those target lesions should be about 1 centimeter or greater if possible. And you try to have no more than 5 per organ. And what we try to do is we try to identify 10 lesions in a patient if they are present so that we can then give a summative value. So what happens is you take the largest diameter of the target lesion, and you'll have up to 5 in an organ, and we use that number, they're summed up together to provide a objective number, and then a percentage of that number is compared with the next scan. So is my total number on the second scan 20% larger, or is it 20% smaller? Is it the same size? Is it completely gone? Has it expanded more than 20%? And those criteria then used to help us determine if there's a complete response, a partial response, progression, have we stayed the same? And that's the basis of RECIST, is to just provide for protocols and to provide for various studies some objective measurement that allows us to know if the patient is succeeding on the trial or if we need to start moving towards some other type of treatment or another trial. So the RECIST 1.1 was just some modifications to try to kind of make it a little bit more user-friendly. But I'll tell you, in many practices, what we have found is that we are more accurate with the RECIST criteria when these measurements are made by somebody who's not reading the study in real time. So in our center, and I think in many cancer centers, what we do is we will read a study for a follow-up of a tumor, making comparisons to many priors, looking for all of the findings that we can, whether they're related to the cancer or not, whether it's related to potentially a pulmonary embolism or findings in other organs. We read those in real time. But then we have somebody who's reading offline who actually sits down with the RECIST criteria, with the table for that patient, and will look at the changes over time to make sure it all makes sense. We feel that this offline reading allows for a more accurate measurement of the tumors to know if the tumor is truly progressing or getting worse, especially when you're close to the demarcation between a partial response and no change. And so I think in many centers, when RECIST criteria are used, they're not actually used by the person who's reading the scan in real time, but used by somebody who's offline. I should mention that immunotherapy has thrown a real wrench in RECIST criteria because it is very easy to just rely on measurements. But what we've noticed is that you can get what's called pseudo-progression with immunotherapy, because you will see that when on patients who get imaged close to when the immunotherapy was started, there may be a paradoxical increase in size of a lesion that's actually responding to the immunotherapy. And then if you did a follow-up study, you see that the tumor starts to shrink. And so that has prompted the creation of a criteria set that's known as iRECIST to take into account of immunotherapy. And so when a patient is on immunotherapy, those will be used as well. It's useful to keep in mind the RECIST criteria. We all expect that as we're starting to use more targeted imaging, especially with nuclear medicine, that we're going to start to see even more of these criteria sets that come into play. But I think it is useful, especially when you're dealing with a protocol or a study, to try to have a radiologist who you work with closely, who you can rely on and who can measure those lesions over time. Having the same person look at the different study time points often results in a more accurate read than relying on measurements alone. So we have learned in radiology that if we remeasure a lesion from an old study, we are much more accurate than if we rely on an old report and take a size from that report and then take our report with a size and try to use that. So the RECIST criteria, they will continue to evolve, but are really nice to have an objective way of following a person who's on a trial or protocol.